December, 4th of December, grade 1. Thank you very much.
Was that online?
Fell apart. Thank you on behalf of my colleagues. I'm even lucky as the locum is in there now. Dimitri, where are you? That's the best photo, and I asked you to send me a photo. I thought this one up, you look at it. Okay, I thought I'd put that. None of those are ACL injuries. I was giving a talk to my 7-year-old's class, and I had to put something scary, so I collected all these photos, and my wife said, no, none of them are those. They were all sitting on my desktop, and I thought, okay, I'm going to use them. The ACL, so this whole session is about the ACL. It is a very simple operation, right? It's blown out of proportion by the fact that when it goes wrong, it can go catastrophically wrong. Secondly, there's an aura of invincibility around the people who can do it, traditionally both, well, in the US, in Australia, and certainly in the UK. But basically, as far as I can tell, you prehab the patient once you've made the diagnosis. You choose the graft, and we've heard there are various options. You put that graft in the right place, fix it so the tension is right, and then you rehab the patient. Actually, a phenomenal amount of those patients do exceptionally well. And one thing, I'm of a generation older than Reg, I can tell you, is that we have learned ACL surgery to this point largely by mistakes that have been made. And very famously, maybe now 15 years ago, Charlie Brown and Freddie Fu, who are the two really big exponents of ACL surgery, said very publicly, I've been doing it wrong all along, because of this concept of not necessarily recognizing what the position of the straight knee is. So think of your MRI scan, sagittally, and how the ACL sits in an extended knee versus the flex knee, which is where you're arthroscoping it, and then deep flexion, right? And where those positions of that femoral tunnel change. And so they said they'd been doing it wrong. My remit is to talk about fixation, and ultimately your biomechanics of the fixation of that graft, you want it to be strong. And the way they compare strength is that they just load these fixation devices to failure, and that says this is the strongest and this is the least strong. The next is the stiffness of the fixation as well as the graft, and that has to do with the resistance to displacement under load. And people will remember that we used to cycle some of our grafts to get the stretch out of it. But in talking about the graft choices, we know that the patellar tendon is much stiffer, as is the quads tendon, than hamstrings, which do. And then the last is slippage of the graft. Here they're not referring to the tension within the tissue stretching, but rather loss of your position or your fixation within your tunnel. All right? And so the ideal fixation is strong enough to tolerate physiological loads and avoid failure. It's stiff enough to restore the stability of the knee. And remember, it's not just that AP translation, but it's the rotationary stability, and it's secure enough to prevent slippage. And so our ideal fixation device is anatomic. And by that I mean it's compatible and fits in with the anatomy, allowing function. It's biocompatible, so it's not going to cause, it's bio-inert, it's not going to cause a reaction. It's safe and predictable in its use, so it's not going to potentially cause any harm. We saw that with very early devices used to fix menisci. They had these barbed tacks that worked very effectively, but if you got them slightly proud, they just eroded the cartilage away on the femoral condyle. They ideally would be MRI compatible, not all of them are, and then easy to revise is something that the ACL surgeons put in. I'm not going to dwell on this because Reg has been through this around what your graft choices are. The reason I've put this in this talk is if you use anything with a bony block, you're immediately restricted by what your choices are for fixation, right? Because most people will default to a screw. The other thing I will say to you is that we've talked a lot about where these tunnels are placed, but the quality of the bone in both of them is very different, all right? And anyone that does it will know that when you're drilling through your femur, it's pretty tough all the way through your tunnel, wherever you're placing it, right? But when you do your tibia, as soon as you're through the cortex, you're in this void, and then you're up at the joint surface where you're starting to see some fat bubbles. So that tibial bone is a lot looser and properly cancellous, whereas your femoral bone is behaving, it's still cancellous bone, but it's a lot more dense. Obviously the cortices, both on the tibia and the femur, are intact, right? And in the tibia, the bone strength falls away rapidly as you move away from the joint line, which is not the case. And also think about modes of fixation as being either direct, so you're fixing the graft directly into the tunnel, or indirect, and those are the suspensory ligaments we'll talk about. It can be at the aperture, which is the point at which, the hole at which the graft enters the joint. It can be intra-tunnel, so somewhere within the tunnel you secure it, or it can be cortical, which is an endo button or a suspensory ligament or a staple on the outside, right? We talked here about tunnel placement, about non-anatomical, semi-anatomical and anatomical, but also I once again just ask you to think about whether your fixation is cancellous or cortical when you're doing it. And so I said this is a very simple talk because really we use aperture fixation with interference screws, and we use suspensory fixation, which can either be cortical endo buttons, suspensory ligaments like that, or transfixion pins, and I'll talk very briefly about that. And this is how I've just described that. So here you have a screw that's going into the bony tunnel, that's a metal screw, that's a biosorbable screw. These are just suspensory devices, and these are transfixion intra-tunnel devices at fixing them, right? And the first one I'm going to talk about is the transfixing devices, because these are redundant, right? I don't know if anybody uses them, and if they do you probably shouldn't. So the way ACL tunnels originated is you drill the hole through the tibia, right? You then, through your tibia, put your guide in to drill your femoral tunnel, right? And if you can imagine, you're immediately restrained by that tunnel as to where you can go, how much you can flex the knee. And then on top of that, the secondary problem, which we didn't talk about, at that point everyone was using bone patella bone. So once you pass your graft through there, your ability to get any fixation into that site became even more tricky, right? Because you were then coming through an anteromedial portal with a flexible nitinol guide to try and get your screw bite in. So you will see x-rays that will show you screws missing the tunnel, missing the graft, screws sitting in the popliteal fossa. That doesn't really happen anymore, right? But that was part of the reason why, apart from in the end people thought anatomic was better, but transtibial approaches kind of disappeared. And also, at that point, we were talking about 11 o'clock and 1 o'clock being our tunnel position, right up at the top. Okay? Even the guys who say they're non-anatomic, nobody's putting it there. But if you do put it there, and you see your guide wire and eventually your tunnel coming out at these points at the top of your thigh, then you can see how a transfixion device of pinning it across becomes quite an attractive proposition of securing your graft in the tunnel, right? Because you're firing across the femur, you will pin it inside you, and you don't have that trouble of trying to sneak your nitinol guide wire from the anteromedial portal into quite a stuffed notch. Okay, so these were in vogue until people realized that they were putting the tunnels in the wrong place, and now almost nobody uses these, right? There's another secret story here, which is when there is a clever idea that people believe works, right, all the big companies will have a version that they build to do it. And then the minute that they think, actually, that was a shit idea, they scrap that, right? And this is a classic example of that. This is pretty much all the big companies had one or two devices that are designs that were designed at transfixing the tibia. They all don't make them anymore, right? So you can see how archaic that is. So I'll stick with the two that we know that we use. So in bone, the gold standard is still using an interference screw. Okay, and it's usually a metal screw, and it has slightly sharper threads than a soft tissue metal screw, right? The reason they use a metal screw is so that they can really cramp that bone into the bony tunnel, and as Mr. Bumber said, they're then relying on a fracture type model of bone healing with bone. The advantage of the screws is they minimize, so the graft, once it's in the tunnel, moves in two real ways. One is what they call a bungee movement, which is up and down within the tunnel, and the second one is a windscreen wiper event, especially if it's not secured close to the aperture, right? So it swings in that direction. So the interference screw, which is going to go in at the hole, is going to minimize the graft tunnel motion, particularly of the bungee effect. It's famous for having less femoral canal widening afterwards, and creep of the graft is less. You get direct access over a nitinol guide wire, so you know exactly where this is going to sit. And if you put them in the right place, once they're there, they have a great track record, both in bone and soft tissue, with the right screw, of holding it in the right place. In terms of the size, the evidence suggests that the screw diameter should be 1 millimeter more than the tunnel diameter for soft tissue grafts. Now that's always quite a sickening feeling, as you've drilled 7.5 or whatever, and you're putting an 8.5 screw in there. Now at that point, if someone has not given you the right screw, so it does not have a non-cutting thread, then actually it will shred your ACL graft if you're using hamstring. Right? So it is crucial that you know what's in the portfolio of screws available to you, whether they be metal, whether they be bioabsorbable, and what kind of thread they are. The other thing they have is Leo Pinchevsky designed this reverse threaded screw, because the whole idea at that point is we wanted to get the graft as far back as possible. So he said in a right knee, as you're turning your screw like this, that's going to push your graft back. But in a left knee, when you're turning it like this, it has the risk of bringing your graft to the front of the tunnel. And so he designed this reverse threading screw that was going to then, even though it was counterintuitive, as you tightened it, it was forcing your graft to stay at the back of the tunnel. But use soft thread screw for short fixation is vital. The argument about metal versus bioabsorbable, there was a big move when anything that was kind of bioabsorbable, all that stuff came out because it was MRI compatible. But there has been evidence that some of them do form granulomas, not the peak ones because they stay, but some of the early truly bioabsorbable ones did. And also some patients can get a larger effusion for longer after their use. The reason people didn't like metal, obviously they were easier to remove, they're easier to put in, but they gave you a lot of scatter if you had to repeat the MRI. Now, when we talk about screws, I'll just go back to what I said earlier. It's crucial that, think of this as the tibia. If you put your screw so that you can't feel it, but it stops here, it takes away a lot of the benefit of being a screw fixation or an aperture fixation. Because in fact, you're tethering the graft to there, and it can windscreen wipe from that point on. So it's quite crucial that you push it up right until the joint surface, and you use a long screw, right? If on the other hand, you over-screw it in, so you use a very long screw, then it can potentially cause damage and actually pain against the fat pad. You don't know what it's going to do when it's sitting there, either in the tibia or in the notch. Suspensory devices is the other way to use it, and these became really quite famous when people started shifting from bone patella bone to hamstring. There are suspensory devices for bone patella bone grafts, but like I said, the gold standard is still screws. And I've mentioned the endo button because that was the one that pioneered the way, and certainly when people went on fellowship, Australia was the first place, although it was designed in the US, that British surgeons went and came back. Most famously the guys who went to see Pete Myers in Brisbane. They came back with this technique of using the endo button, and it almost became the gold standard. In fact, I can remember the last ACL teaching session when Adil and Cash ran the session. It was almost entirely about the endo button and hamstrings being the way to treat ACLs. And the idea is it gives you suspension against a rigid cortex, which is very predictable. But the downside was it may lead to tunnel widening. It's called the first generation suspensory fixation simply because they've evolved a second generation, right? But the idea for all of you guys to understand is there's one bit which is the insertion part, right, of the graft, and then there's a narrower bit of tunnel that you drill through which only a button side on is going to pass. So you pull that button up the narrow drilled bit, which is 4.5 millimeters, so it comes up here, it's still standing on end, and then when you pull it back down, it's going to sit like that against the cortex, and that's the suspensory device. Okay? But as a consequence, you have a potential problem, right? Because you need to pull it up to here to get the button through, and then when you pull it back down, it leaves a dead space. All right? And you can imagine, let's just say for the sake of argument, most of our surgeons are very good, so they leave a minimal dead space, and you measure, there's a bit where you do the maths around how long the button thread is of the endo button. But if you were to do this badly and leave it down here, you can see that pivoting or the pendulum motion for the windscreen wiper effect on tunnel widening is going to become a real problem, right? And that was a concern for anyone who was using these. Even if the patient was still functioning very well, you were getting lateral radiographs, which were often taken for something else because these guys had got back to high level activity, and you were seeing this cortical kind of cone-shaped tunnel, where you were hoping by this stage Sharpie's fibers have caused integration of your graft, right? And that was a worry. So the tightrope, again, like the endo button, was the first of the second generation, right? Which is where they said, how can we still use this suspensory fixation model, but actually eliminate that dead space, right? And what they do by having a loop, they can control the length of that red line, which is the loop, right? So you pull the button through and you flip it, and then you walk your graft right up so that you've eliminated the dead space, right? So if you do that properly, you can see there's no space for a windscreen wiper effect to take, right? And so people who then thought, could see the disadvantage of the last, moved to this, right? And almost as soon as that became kind of well established, you started seeing this in all of the sports literature. Comparisons, right? Whether it was loading to failure, but every single device would be lined up, there'd be load to failure, and depending on what the bias of the writing team were and who was sponsoring it, you'd say, this is way better than the other one, right? The downside against the tightrope initially was that that movement where you walked it up actually cheese grated your graft, and so your graft became weaker, right? That was the argument against it. But what this told me actually is a wider story, which I mentioned earlier, which is that if an idea is a good one, all the major companies will develop their own concept, right? And Reg didn't really talk about this in the graft tunneling, but when they moved to anteromedial, there was a problem with hitting the condyle as you went in, right? And so some companies spent a lot of money making a clover-shaped drill, which was half a drill, so that you could slide right up against the condyle without damaging it, and then that would complete your tunnel in terms of drill. And all the companies now have these flexible drills that will allow you to get around the corner so you can still go anatomical. Smith and Nephew, and now they're claiming that because they've got 3 loops rather than 2, it doesn't cheese wire as much. But you can see this is Mytech, Limitech, Zimmer, Stryker. They've all developed a variation on what we're calling now a second generation suspensory device. What is the benefit and why have they done this? There's one thing which is walking it up. The second is what your fixation on the tibial side is, and we've talked about an aperture fixation. A lot of people have done this study independently, which is however you try and hold on to your graft. You get the biggest guy who can pull on your graft. As you put an interference screw in, it is going to push your graft up, right? And it pushes your graft up, maybe very little, right? But that's going to lose you tension in the graft. And remember, my original thing that made an ACL a great operation was if you could fix it properly with the right tension. So what these adjustable things also allow you to do is if you don't pull your graft all the way up into your tunnel, right? And then you put your interference screw in, you can then walk it up the last bit to get the last bit of tension out. And that's a secondary benefit, apart from the windscreen wiper failure, why this is increasing in popularity and all the companies are doing it. Just as a point of reference, this movement of a graft as you secure it is not a new problem. I don't know if any of you remember this, but I remember doing an ACL with Tom Bucknell when this thing first came out from Mytech. It was a huge contraption that you tied the 4 strands of your graft to, and that would pull as a machine as you inserted your kind of a sheath that went in there to secure it in the tunnel. And this is Apafix, which I have to say Josh has used on some occasions in the femoral tunnel. So it goes in through the femoral tunnel, but this thing widens, squeezing the graft out, and he says it gets great aperture fixation. He's very happy with it, both with the Axis, but it hasn't gained the popularity to replace suspensory devices. So anyway, this was the problem with the maths of the endo button, trying to determine if you wanted to minimize that dead space, you had to kind of work out how long your graft was, how long your tunnel was, how much the graft was going to be in the tunnel, and then work out what length of button you had to put in to flip it. And I put this slide up principally because now we've moved with the tightrope and the suspensory device to an all-inside technique of fixation, right? So you use the tightrope on both sides, on both the tibia and the femur. And I, in my personal practice, have not moved to that, and I'm explaining to you why. doesn't make it right or wrong, and Reg is absolutely right. You have to do what you feel is right in your own hands. But it goes back to maths. If you don't get your maths right and you go for it, you're going to have a dead space again. Except bear in mind, this is tibial bone. So that windscreen wiper effect is going to be far greater than if that was femoral bone, right? So it can be done, and if you get that accurately, it's going to be a great fixation, but there's a lot of maths that you have to do, both in terms of measuring your graft, knowing what your intra-articular graft length is, but also how far you've drilled back with your flip cutter, if that's what you're using. And as a consequence of that, this is something I've never done, but I've just been reading up for this talk. Surprising as that may be. But people are now recommending tunnel dilatation for the tibia. So they're saying ream 2 millimeters underneath, and then rather than removing the bone, use these dilators so that you compact the bone for the final 2 millimeters, which will give you a much tighter canal into which you can fix your graft. I've never done it, but having done this, I might find out if that's an option for me. So, to conclude, ACL reconstruction is a very easy operation. Make the diagnosis, prehab the patient, choose the graft, put it in the right place, fix it so the tension is right, and then rehab the patient. And these are the examples I was telling you about: screws missing, tunnel widening, and they've all, that's how it's kind of evolved to this point. Thanks very much. That says this message has been deleted. Any questions?
So I think this member may have covered it, but is there a difference in the post-op rehab between bone-to-bone and graft?
Well, so the simple answer is I have no idea, because everybody is now rehabbing their patients in a very different way, right? When I started doing ACL, I did bone patella bone, I did it transtibial, and I used screws. I then put all those patients in a knee brace because that's what I'd been brought up to do. And the guys who taught me were Tom Bucknell, Malcolm Glasgow, and Paul Allen, right? Who were all, and Tim Briggs, who were all bone patella bone transtibial. That is probably the strongest construct. I now use a flip cutter, a tightrope, and a hamstring, and I don't brace them at all because I'm so confident with both the graft construct and their ability, the crucial things that they get going. So to answer your question, every surgeon, irrespective of graft and fixation, kind of works out either their own rehab, which they then spread out to all of the physios, or they're so happy with the construction, and physios, particularly in private practice, you have no idea where your patient's going to go. At least in the NHS, you know they're going to go to that physio department, so you can send them a protocol. People are saying, well, ACL rehab is pretty standardized. I'm happy with my fixation. Go for it. And so I know it's not a real answer, but that's the reality, is people just pretty much standardized ACL rehab and they go for it if they're happy with their graft. There are people who are not happy at the time of the surgery, where at the end of it, when you know they say, have a feel of that, oh, not so hard, right? And you're doing the Lackman. Those guys want protection, so they will put a brace on and make sure they know which physio they're sending to, and probably have a word about holding back. Slow track, I think.
And that's very true. Exactly as Mr. Achan said. Because a lot of people do accelerated rehab. The only difference really is most people let BTBs now go back to sport at 6 months, whereas hamstrings are still at 9 to 12 or 9. So that's the only real difference. But the rehab tends to be the same.
How do you judge how much tension to put?
How much tension to put on the graft? Yes. So you basically need your graft to be tight. If you've got your imagine the apertures of both of your holes, however you've decided to drill them, are in the right position, then within that space you can't have any laxity. So basically you're pulling it just as tight as you can physically. All of these, even including bone patella bone, even though that's in millimeters, all of the grafts will then stretch a little bit, whether you cycle them or not. Usually over the first 6 to 8 weeks, there's a little bit of give. It's in the millimeters, it's in the micrometers with a bone patella bone, but there's a little bit of give. So you're never going to get that 100% kind of rock solid tension. But there is a counter argument that we haven't really talked about here, which is if you use something that is very stiff and very rigid, like bone patella bone, and there's a definite, I'll talk about this very briefly, but about footballers and elite athletes having bone patella bone, there is an argument that that stiffness then contributes to increased joint pressures, and these people may then get early arthritis. And at the Pop Club, Stefan Lohmander came and talked a lot about that, right? So what happens traditionally with a footballer is they have a significant knee injury at 22, 23, and they would have an ACL done. They would get back to playing Premiership football, but that graft would stretch. But because of their quad strength and the active rehab and the fact that they have a physio team, they would perform and perform. And then they would come to their 28 to 30 big money transfers, the final transfer, final contract. And at that medical, they would have a significant degree of laxity, right? Because the graft is stretched. And then somebody would be saying, oh, we're not going to pay this kind of money because you've got a shaky knee, right? And that has pushed, and this started like all things in the US with American football, but basically as a consequence of that, people are saying, well, we need what's not going to stretch at all for these professional athletes. And if you speak to Andy Williams, he will say that's what's really pushed him back in the elite athlete group to going back to a BTB graft.
There's another slight argument in the elite athletes that some people used to give using the bone patella bone over their hamstrings. What's the most common injury for a footballer?
Hamstring.
Hamstring strength. So if you've taken out their hamstrings, you're weak in that as well. But all this talk about stiffness of grafts, we don't actually know what the end stiffness of the graft is biologically. All those tests biologically, and I did a whole load of this when I was doing my research, it's all about day one fixation. When you put it in, how stiff if you load it, and there's changes in the load, the rate of loading, what the stiffness of the graft is, whether it's hamstrings or bone patella bone or quadriceps tendons, 6 months after it's been biologically inserted. You don't know, because there's a whole revascularization, proprioception, ligamentization gone on. So we don't know. More of the constraint comes from that, getting that tension in and getting that rigid fix and having less of the stretch.
And so in these elite athletes, the footballers, although they're using bone patella bone, clearly they're using allograft, right? So when Paul Gascoigne had his done, he used autograft and they fractured his patella. And that was pretty much a career-ending thing, his ACL injury, not because of the ACL rehab, but because of the patella fracture he had at the same time.
Right, thank you very much. That was a brilliant lecture.